Hello and welcome to Melbourne IVF's very first live webinar. My name is Morgan and I'm the Community Liaison Administrator here at Melbourne IVF. Thank you for joining us this evening as we discuss all things about fertility and fertility treatment options available to you. You'll notice on the right hand side of your screen there is a small white box. By clicking that box you'll have access to a Q&A tab. Please feel free to type your questions in throughout the seminar and we will be able to answer some of those questions at the end of the presentation. I would now like to take the opportunity to introduce our Melbourne IVF fertility specialist, Dr. Melissa Cameron. Dr. Cameron is a fertility specialist and gynaecologist specialising in infertility, reproductive endocrinology and laparoscopic surgery. With a focus on fertility issues affecting women with endometriosis, fibroids and uterine abnormalities, Dr. Cameron helps couples with some of the most challenging fertility problems. Dr. Cameron also has a special interest in helping same-sex couples and single women create a family through using the Melbourne IVF donor program. Welcome, Melissa.
Thanks, Morgan. And welcome to everyone to our first Melbourne IVF webinar. I hope you find it really interesting and ask some good questions that we can get back to on. So we're just going to start the presentation now. So tonight we're really going to be talking about just giving you a general understanding about fertility and also fertility treatment. What do we do here at Melbourne IVF? Even though we're called Melbourne IVF, we do so much more than just IVF. We often offer fertility advice. We have a lot of different fertility treatments, very simple treatment, very advanced treatment, using various scientific techniques. We have a large donor program through Melbourne IVF, including egg, sperm and embryo donation. We also have a surrogacy program running through IVF now. We provide some very important fertility preservation services, both for patients who have medical reasons to need to preserve their fertility, but also increasingly women that want to preserve their fertility for future use. A really important part of what we do is research and development, so trying to make what we do even better. And we also offer a lot of support through our counselling and nursing team as well. So first of all, I'm going to talk a little bit about diet and lifestyle and some preconception health. So what can you do, even without seeing us, to try and improve your fertility as much as possible? First of all, if you're planning a pregnancy, there's lots of things to think about. This is the time of your life where you want to become the fittest and healthiest that you've ever been, not only to improve your chances of fertility, but also to help yourself have a really healthy pregnancy and also look after a little one when they come out at the other end, because the healthier and fitter you are, the better it is for everyone. First of all, with folic acid is a vitamin, and we recommend that you take that for at least 3 months before trying to get pregnant. It's a really important vitamin in the development of the spinal cord, and taking this and having a supplement reduces the risk of spinal tube problems and we recommend most people have a multivitamin, so there's various women's and men's multivitamins on the market. Just ensure it's a pre-pregnancy one and from a reputable brand. It's really important you have a healthy BMI. I see a lot of people who do struggle to conceive, and a lot of the time it's due to things that aren't changeable. They're not easy to change, but certainly things that are changeable, such as being overweight. So you maintain a healthy BMI. My BMI means body mass index, so that's comparing your height to your weight. Regular exercise is really important. Don't overdo it though. You certainly can overdo exercise, and that can have an impact on periods. Having a healthy, balanced diet is incredibly important. Certainly limiting alcohol and caffeine. Stop smoking. If there's ever a time in your life you're going to stop smoking, now's the time to do it. We know that smoking certainly reduces your chances of getting pregnant in the order of somewhere of 50%. And that's not only getting pregnant spontaneously, but also when you come through IVF as well. Obviously, we would recommend stopping any recreational drugs. Not only could they affect your fertility, but they can certainly have impacts on developing babies as well. And it's a good idea to pop along and see your GP for a pre-pregnancy checkup if you are thinking about becoming pregnant in the next few months. Your GP may do some blood tests, such as order a whole heap of what we call pre-pregnancy blood tests. So these are usually ordered as a routine. We like to make sure you're immune to both chickenpox and rubella, otherwise known as German measles. There's certainly been more and more cases of chickenpox around, particularly in the last year. And it's not that it will affect you getting pregnant, but certainly if you get chickenpox when you are pregnant, it can be very dangerous for the mum, but also for the developing baby as well. And usually we check your blood group, and if you have any antibodies to blood groups, check a part of the blood type called a rhesus factor. We do various infectious disease screens as well as a full blood count. It's a time to also make sure your general health's up to date and as best as it can be. So I recommend making sure you're up to date with pap smears, have a breast check done to ensure there's no concerns. And sometimes we'll also offer pre-pregnancy genetic screening advice. So nowadays there are tests available to see whether you're a carrier for some genetic conditions such as cystic fibrosis, and there's some others we test for as well. So if you are trying to get pregnant, when is the best time to try? What this graph demonstrates here is a pregnancy window. So when we say pregnancy window, this is the time that if you have sex, you're most likely to conceive. If you look at the top line there, there's numbers 1 to 29. These are days of the menstrual cycle rather than calendar days, where day 1 is the first day of the period and day 28 to 29 is the first day of the next period. And as you can see from here, if a woman has a 28-day cycle, she's usually going to ovulate around about day 14 or 15. Eggs last between 12 and 24 hours within the reproductive tract. Sperm is a little bit more robust. It can last even to up to 5 days in the reproductive tract. Now, once the sperm has been released near the cervix, it does have a bit of a trip to take up through the uterus into the fallopian tubes, right to the end of the fallopian tubes near the ovary, and that's where it meets the egg. So ideally, we want the sperm on board, waiting in the fallopian tubes, waiting for that egg to pop out. So this is why we recommend that actually prior to ovulations we should have intercourse. So we recommend having sex every second day in this green area. Now, obviously, the time of ovulation does change if you have a longer menstrual cycle. So if you have a 35-day cycle, often you ovulate about a week later, so around about day 20 to 21. The last 2 weeks of the cycle, which is fairly consistent between people, whereas the development of the egg in the first few weeks can vary quite a lot. This graph is really interesting and I think important to take into account. Even though sometimes, particularly when you're trying to fall pregnant, it seems like everyone around you is just falling pregnant at the drop of a hat. If you actually look at the numbers, only about 20% of couples per month will get pregnant. So we're not as good, or it's not as easy to reproduce as you might think. If you look at the graph, as you can see over time, the longer people try, the more likely they are to get pregnant. So after 6 months, about 60% of couples are pregnant. 12 months, 80%, and after 18 months, 90% of couples are pregnant. So there will always be some couples right at the top of that graph who aren't able to get pregnant naturally. And it's about 1 in 6 couples who will need our help to get pregnant. So why are we not falling pregnant? One of the most common reasons I see for couples not being able to get pregnant is related to age, in particular, age of the female. This is because of egg stores and egg reserve, but also egg quality, and I'll go into that in a minute. Now you can see on the left side, on the axis, the up and down axis on the left-hand side, with the blue dots, that just demonstrates what the natural fertility rate is like throughout time. On the axis down the bottom, we have age. So as you can see, people in their early 20s, even up to your early to mid-30s, it's reasonably easy to get pregnant with a fairly high fertility rates. After the age of about 36, 37, the natural fertility rates do start to go down, and certainly once you reach your 40s, the chance of getting pregnant is quite low, somewhere in the order of about 20% overall. On the right-hand side, we have our IVF pregnancy rates, and it kind of mirrors that, although we do find that using IVF in the early to mid-30s is the time when we do get very good success rates, and certainly we can do much better than natural conception rates. Again, with IVF though, if you look at the other end of the scale, even with IVF, it is still much harder to get pregnant when you reach your 40s. A lot of this has to do with reduced egg number and also poor egg quality. And you can see from this graph that women are born with a certain number of eggs. We're born at birth, we have around 1 to 2 million eggs, and that's what we've got for a lifetime. We're born with a basket of eggs. It's been described to me as a gift of eggs from your mother. You're born with a basket of eggs, and that's what you've got for a lifetime. By the time you reach puberty, it's down to about 400,000 eggs. It's not that those eggs have been released, they've just disintegrated over time. And these are the eggs that are slowly released over the reproductive lifetime. So it's not that you just release one egg per cycle, you actually end up recruiting about 20 eggs, so about 20 eggs turn up each cycle in the hope that they'd be the one that's good enough to be released. So you may get 20 eggs, but usually only one egg's released per cycle. And this goes on until menopause, during which time the egg quality is declining considerably, but also the egg number. Other major causes of female fertility I do see are patients with ovulation problems. So they may have very irregular ovulation. And ovulation means releasing eggs. They may only release an egg once every 2 or 3 months, maybe even less frequently than that. Polycystic ovarian syndrome is one of the causes of ovulation problems, and we do see this quite frequently. It's one of the most common conditions we see within our female population. Endometriosis is a condition that's often associated with pelvic pain, pain with sex, pain with using bowels, pain with using bladder. And it's a condition where some of the lining of the uterus is growing elsewhere in the pelvis, so near the ovaries, behind or in front of the uterus, near the tubes, and so on. It creates quite an inflammatory condition inside the pelvis, and it makes it a bit of a hostile environment for eggs and sperm and embryos. Obviously, the tubes are vitally important to conceive naturally. So the tubes are like the highway where the egg and sperm meet. So the sperm travels up the tubes to meet the eggs. If the tubes are blocked, then there's a physical blockage between the egg and the sperm meeting each other. Same as if they're damaged. The tubes are very, very fine, very fragile structures, and they're easily damaged by things like infected appendicitis and so on in some cases. There's also a group of women who have changes to their uterus, so there may be changes to the anatomy of the uterus, which does make it harder to get pregnant as well. What about men? Why are we not getting pregnant? Major causes of male infertility. Mostly we see problems with sperm. The most common problem I see is a high number of abnormal sperm, and you can see from the diagram on the far left is the normal sperm, and all the other fellas are abnormal. Now these guys either can't swim in the right direction, can't swim at all, swim around in circles. They may also not possess the capability to actually penetrate through the egg. The sperm needs to go right into the egg to be able to fertilise it. There may be sexual difficulties such as impotence. There may be some sperm antibodies present, which is then compromising the quality of the sperm. Again, lifestyle factors are really, really important. And at least 30% of people will have problems with male factor infertility. It's about 30% of female factor infertility, but an awful lot of it is often unexplained, or there's a bit of both in both sides. So if you seek advice from your GP or your fertility specialist, what should you expect them to do? First of all, usually a GP will arrange some tests to make sure that ovulation is occurring, give some advice regarding menstrual cycle, advice about when the best time is to conceive, what sort of signs to look out for ovulation, such as changes to the mucus, pain, and so on. There are various ovulation tests that can be done, and I'm sure a lot of you are aware of the ones that you can get at the chemist, where most commonly you can wee on a stick and it will tell you whether you're about to ovulate. There are also some saliva tests around. Personally, I find them really difficult to interpret. I think the urine tests are much more accurate, so if you're going to pick any, pick one of the urine tests. Pelvic ultrasound is often ordered to ensure there's no overwhelming pathology within the pelvis that could be attributing to not getting pregnant. And for the man, usually a semen analysis is arranged. Now, it's really important if you have a semen analysis done, make sure you get some instructions as to how to collect the sample, how to prepare for the sample in the days prior. It's really important you get the sample to the lab quickly, or most labs, most reputable labs, such as our specialised lab here, will offer facilities where collection can occur on site, and therefore the sperm can be analysed as soon as possible. Once you reach the fertility specialist, they may repeat or do some more of these tests. One of the tests we do tend to order is a thing called an anti-Müllerian hormone. This is a blood test that's done to measure of ovarian reserve. So all of those little eggs that are sitting dormant inside the ovaries can produce this substance, and we can measure that in the blood. And it gives us a bit of a surrogate measure of how active the ovaries are. By no means does it tell us exactly how many eggs are left, and it doesn't tell us anything about quality of eggs. Personally, I find it's a very useful test to help counsel people. So if I get a young woman coming to see me who isn't sure whether she wants to have babies yet or not, wants to get a bit more advice, then this test can be helpful as far as counselling goes. It's also very useful from a practical level when you're talking about doses of medications and how people might respond to an IVF cycle. There may be a specialised ultrasound ordered. This is most frequently to check the number of follicles, or what we call an antral follicle count, so checking the activity of the ovaries early on in the menstrual cycle. And there are also tests you can do to check the fallopian tubes and make sure that the fallopian tubes are working. The fertility specialist would usually take quite a detailed history from both the male and the female partner, and then there may be other tests that come up that become necessary throughout all of this. The one thing I would say is don't delay. If you've been trying to get pregnant for 6 months or more, it's certainly a good idea to pop along, get some advice from your GP at least, or even come along and see one of the specialists here. Particularly if you already know that there's a pre-existing problem of some sort, so you've had a history of endometriosis, you know that you've got polycystic ovarian syndrome, and certainly if there's anything there that you're worried about, certainly pop along to your GP or come see one of the specialists at Melbourne IVF. What about complementary therapies? There's estimates that around 80% of patients will use complementary therapies. It's something that my patients talk to me about almost every day. I would almost be struggling to find a patient that comes to see me who hasn't already tried something. I think they're a very good idea in many situations, but unfortunately we don't have a lot of evidence to show that they work. My main concern is that whatever you do, make sure it's safe, both for you, but also for a developing baby if you are pregnant. We have a lot of patients using acupuncture, and there is some early evidence that acupuncture may be a benefit. It's certainly not magic, but there are some studies showing that it does increase pregnancy rates slightly, and we're involved in quite a large study at the moment just to look at that very question, to see whether acupuncture in women undergoing IVF actually improves the number of babies that are born. So if you're not falling pregnant, what are the options? What should you expect? First of all, it may be as simple as tracking the cycle. So this can involve ultrasounds and blood tests to determine when ovulation is occurring. That can help you time when to have sex. If there are difficulties with ovulation, there's various methods we can use to make ovulation occur, and it may either be tablets or injectable forms of medication as well. Intrauterine insemination is a procedure where we take the sperm and put it directly inside the uterus around the time of ovulation. This can be very useful for couples, particularly those who require donor sperm, so single women in same-sex relationships, or women in heterosexual relationships where there's a significant sperm problem. Some people will benefit from fertility surgery. This is particularly if you have fibroids, so some fibroids, which are benign tumours of the uterus, can interfere with fertility, or endometriosis. Treatment of endometriosis can certainly improve natural fertility rates. You may also want to consider egg freezing if you're not wanting to go ahead having a pregnancy at this stage. This is certainly an option for women in their 20s and early 30s. It's still an option for women later in their 30s, but really the benefit is if your eggs are frozen over early on, where you still have a good egg number and also a good egg quality at that stage as well. Then we really move on to our more advanced techniques, and this is really where we're talking about things such as in vitro fertilisation, which is where the woman is given medication to produce a number of eggs. These eggs are then collected by a relatively minor surgical procedure. The eggs are fertilised outside the body with the male sperm. And one of the ways of fertilising the eggs is using a procedure called ICSI, or intracytoplasmic sperm injection. That's why we call it ICSI, because it's such a long way of saying it the other way. And this is a procedure where we directly inject a single sperm into the egg, and you can see that there. It actually looks like a little scratch on the screen, but if you look in that bottom diagram, you can see a tiny little sperm that's been directly injected into the egg. So how does this all start? Once your specialist has determined that yes, you do need to have IVF, there's a few things we need to do before treatment actually commences. You meet with our nursing staff who teach you all about the different cycles and the medications and how to give them. Counselling is part of the workup we do as well, and you also meet with our administrative staff as well. Then the medications commence. During an IVF cycle, there's a reasonable amount of monitoring that happens, both blood tests and ultrasounds. Most people can expect 1 to 2 ultrasounds as a minimum throughout their treatment, but it really does vary. There's various ways of stimulating your ovaries. Then we have the egg collection procedure, and on the same day, that's when we also require a sperm sample so that we can fertilise the eggs with the sperm. Now, between 2 and 5 days later, once we allow the embryos to develop, and then we perform the embryo transfer, so that's where the fertilised egg, once it's starting developing and advanced a bit, we put it directly back inside the uterus. And then there's the long wait until the pregnancy test, 1.5 to 2 weeks later. We also have some fertility treatment options, such as pre-implantation genetic diagnosis. So this is a technique we use where we actually biopsy embryos. So we're taking a sample of one of the embryo cells. We then check its chromosomes. This can be really useful for people who have in their family a genetic condition that is known to be attributed to a certain gene, and we can test for some of those genes in PGD. Also for screening for chromosomal abnormalities, such if there's been a failed IVF cycle, advanced maternal age, so women as they get older, there is a higher risk of conditions such as Down syndrome, and some women at this stage will elect straight up to do PGD as opposed to standard IVF. Some situations of recurrent miscarriage, with chromosomal abnormalities being one of the most common causes of recurrent miscarriage, or if there's been a chromosomally abnormal pregnancy in the past. We also have an extensive donor program, as I mentioned before. So we have egg donation, we're very involved in the sperm donation program, as well as embryo donation, and our surrogacy program is also quite extensively used. Why should you choose Melbourne IVF? First of all, we do try and offer one-to-one patient care. So you choose your fertility specialist, and it's our aim that that specialist is the one who manages your cycle, performs your ultrasounds, performs your procedures throughout the cycle. I think that's really important. I find from a specialist point of view, that gives me a lot of feedback as to what's happened. I like to know what's happening to my patients. I like to be involved one-on-one with their care. Certainly makes it much more fun and much more, well, trying to think of the right word, but it's really it's what makes it for me from Melbourne IVF. We associated with each specialist is a team of nurses, somewhere between 1 and 3 nurses dedicated to each patient. So you'll have at least some continuity when you're ringing up, talking to the nurses, and certainly the nurses do help from a day-to-day basis, helping with your scheduling, so you know exactly what you should be doing every day. I'll show you in a minute how extensively we are around Melbourne and Victoria. So convenience is really important. A lot of the time you're coming in for scans multiple times a week. You need to take time off work, etc. So it's wonderful if you can find somewhere that's closer to where you work, that's more convenient for you to minimise any disruption to day-to-day life. Also regarding our advanced technology, we're certainly in the forefront of a lot of, particularly with our PGD team. That is something that we're advancing all the time. And we also aim for individualised treatment rather than having a protocol-based one-size-fits-all. Really important factor with IVF is that no two couples are the same, and no two treatments should really be the same. This is a picture showing all of our fertility specialists. There certainly are a lot of us. We all have different interests and different areas of expertise. So if you click on the profiles on the Melbourne IVF website, you'll be able to have a bit more of a read about what we do and what we're interested in, and hopefully find someone who suits your needs. And as I said before, we do have a lot of locations throughout Melbourne and throughout Victoria. We have 6 fertility clinics, 4 day hospitals and embryology laboratories. All of the private specialists do consult in various locations as well. And some of our fertility specialists are also happy to take phone consultations, also Skype consultations for patients in the country or interstate or even overseas. So we might open it up to questions now.
Yes, thank you, Melissa. So we're now going to address some of the questions that came through during the presentation. So Melissa, the first question that came through was, I am 38 years old and relatively healthy. When should I start seeking help?
Well, certainly at the age of 38, I would start seeking help sooner rather than later, even if it means just going to see your GP for advice or seeing a fertility specialist for advice. The thing is, we all know time passes really quickly. At the age of 38, if you're only just starting to try and get pregnant, we do know the fertility rates do decline over time. So certainly after trying for 6 months, in that situation, I'd pop along and start asking for some advice.
Fantastic, thank you, Melissa. And another question we had, if my husband has had a vasectomy, what are my options?
Well, there certainly are lots of options. There's the option firstly for reversing the vasectomy, so undoing the plumbing and reconnecting the pipes. And we have specialists at Melbourne IVF who do that. You can also bypass the plumbing and do a testicular biopsy to retrieve sperm that way and use sperm in that manner. In some situations, you may also want to use donor sperm, but there's certainly at least, there are a lot of options available, and that's something you should talk to your specialist about.
Fantastic, thank you. And finally, Melissa, if I am a single woman, what are my options?
As I said before, we do have our donor sperm program through Melbourne IVF. So we have a lot of single women now presenting to access our donor sperm program. In Victoria, and one thing I must say, I don't know how many people are from interstate, but fertility legislation is a state-by-state basis. So for people in Victoria, single women can certainly access donor sperm program, no worries whatsoever. So again, if you go and see your GP as the first step, get a referral to one of the Melbourne IVF specialists, and then we can help you along that journey.
Fantastic, thank you, Melissa. Well, that's all we have time for tonight. Thank you very much for joining us this evening on this webinar. We will make contact with you in the near future to gain some information about what you thought of tonight's webinar, and also to see if you have any other further questions that we can help you with, or perhaps if you're interested in making a consultation, we can help you out with that one as well. So thank you very much for joining us this evening, and have a good evening.
Thank you.